Bueno, bienvenidos a todos. Muchísimas gracias nuevamente por estar presentes hoy sábado. Mi nombre es Veronica Busoni, soy gastroenteróloga pediatra del Hospital Italiano de Buenos Aires, Argentina. Y este es un webinar organizado por el Working Group de Falla Intestinal de LASPGHAN, que lideramos junto con la doctora Daniela Gattini, que próximamente va a presentar a nuestro invitado. Queremos agradecer también al doctor Espolidoro por su apoyo y recordarles que la conferencia será en inglés y que pueden hacer sus preguntas tanto en inglés como en castellano como en portugués, que podrán ser traducidas para la discusión final. Y por último les solicitamos que apaguen sus micrófonos para no interferir con la conferencia. Así que los dejo con la doctora Daniela Gattini para que presente a nuestro invitado.
Gracias, Verónica. Bueno, hoy día tenemos el honor de tener al doctor Lorenzo Norsa con nosotros. El doctor Norsa es gastroenterólogo y hepatólogo pediátrico de Italia. Él hizo su especialización en la especialidad en el servicio de gastroenterología, patología y nutrición pediátrica del Hospital Necker des Enfants Malades de París, Francia, bajo la supervisión del doctor Boulet. También realizó un magíster en gastroenterología, patología y nutrición pediátrica en la Sociedad Francesa de Gastroenterología, Patología y Nutrición Pediátrica. Actualmente es profesor asociado en educación superior en Italia y desde el año 2017 se trabaja como consultor en gastroenterología y hepatología y trasplante en el hospital en el servicio de pediatría, patología y trasplante de ASSP Papa Giovanni en Bergamo, Italia. El doctor Norsa tiene más de 53 publicaciones y ha recibido numerosos reconocimientos y premios, incluyendo actualmente la lideración de un networking grant de LASPGHAN, con un proyecto sobre teduglutide, el registro de teduglutide en distintos países de Europa. También ha sido receptor del premio a Mejor Trabajo en el Congreso Internacional de Trasplante de Intestino en Buenos Aires en 2015. También recibió un reconocimiento en su proyecto, el efecto del ácido salicílico en niños con colitis ulcerosas, un estudio randomizado, y también recibió otro reconocimiento por su trabajo de resistencia a la insulina y salud cardiovascular en niños con enfermedad celíaca en los países mediterráneos. Hoy le dejo la palabra al doctor Norsa. Thank you very much, Dr. Lorenzo, and I'll leave the floor for you.
Gracias. Voy a empezar un poco español, después voy a pasar al inglés. Gracias al profesor Sparidoro, a Daniela y Veronica per l'opportunidad de mostrar los resultados de nuestro trabajo de registro internacional europeo sobre el uso de teduglutide en real life. So I will switch to English just to be more proper in the speaking, because my Spanish, I think, ended like this. I'm very happy to present these results on behalf of all the countries that have now adhered to this project of a real-life registry on teduglutide in short bowel syndrome and the use of teduglutide in real life. We will just start a bit with like a background. As we know, when we speak, you all know, because as I understood, this is your special interest group of intestinal rehabilitation. When we speak about intestinal rehabilitation, we have in the first, from birth until the second year of life, an important medical and surgical management to try to improve intestinal absorption. Then, from the 2 years of life on, the intestinal rehabilitation is mostly done by home parenteral nutrition, which is nowadays the pillar of intestinal rehabilitation and is the best option for patients with short bowel syndrome. And then, unfortunately, there are some patients, and we all know them, that cannot continue on home parenteral nutrition because of very, very difficult very, very important problems like vascular access problem or intestinal failure associated liver disease. And so they developed what is so-called nutritional failure, and then they need to progress to intestinal transplantation. I think in this pyramid, since the latest probably 5 years in pediatrics, we can add a new component of this pyramid, which is the idea that before intestinal transplantation, we could probably try new drug treatment. This is how GLP-2 was discovered back in the around 2014. It was discovered because they were doing studies on human proglucagon and the molecule GLP-1. From those studies, they found out that GLP-2, which was another metabolite of human proglucagon, was actually a very important hormonal factor for intestinal targeted cells, so intestinal GLP-2 targeted cells, which has a receptor of GLP-2, and this GLP-2 is usually produced more by the terminal ileum and the colonic mucosa, and the receptor are more present on the duodenal and jejunal intestinal target cells. When the GLP-2 comes to the intestinal target cells, it releases mediators such as IGF-1, RB ligand, and other mediators, which has an important endogenous action, like intestinal mucosal adaptation to enteral refeeding. They enhance small intestinal, they reduce small intestine susceptibility to mucosal injury, and they enhance Paneth cells function in the enhancing the intestinal host microbiota interaction. As a result of all this mediation, we have an increase in villi and an increase in cell crypts, as you could see from these slides. From this discovery, they tried to engineer a new GLP-2 analog, which could resist more to degradation, because we know that in nature, GLP-2 has a degradation of around 7 minutes, the endogenous GLP-2, while by adding in position 2 glycine amino acid, they were able to enhance the half-life of this new GLP-2 analogs, which is called teduglutide, to nearly 2 hours in healthy subject and 1.5 hours in patients with short bowel syndrome, intestinal failure. This had the first results were in preclinical and in clinical effects of this GLP-2 analog, were in preclinical the stimulation of mucosal hyperplasia, the enhancement of and magnitude of intestinal adaptation, the restoration of absorptive capacity in animals that were intestinal resected, and increased absorption also in animal that was unresected. While in clinical practice, we had some the first one to believe, I would say, in this very, very important novelty for our community were the group from Copenhagen in Denmark, led by Professor Jeppesen, which ran the first clinical trial in adults, and they saw that with the use of GLP-2 analog, we could have a reduced energy excretion and improve energy absorption. We could reduce the need of PN and IV fluid. We can increase small bowel villus height and increase colonic crypt depth. So from the adult, we know that the first trials were published in the early 2000s, and we had this phase 3, the combination of the two phase 3 trial of GLP-2 analogs was published in 2010 and enrolled 134 subjects. And we could see that if we define the response to teduglutide by a reduction of at least 20% of PN or volume PN requirements, which could be either caloric requirements, either volume requirements. In this phase 3 trial, they had a percentage of responders around 50%, from 46 to 63%, with a response at 52 weeks of 68%. The percentage of PN weaning in this trial was of 12%. Then in the adult population, we had some publication of real-life experience, as you can see here, mainly from the US. These were all publications in the latest 4 years, and were mainly from US, from Germany, because we know in Europe that Germany was the first country to put in commerce teduglutide, and from France. And as you could see, the results were a bit intriguing, because some of them in real life showed higher response rate and PN weaning that phase 3 trial, while other studies showed a very low, less response. So we still don't know where is the real cutoff, and for sure the problem is that we really don't know which are the best candidates for this treatment. Then from those evidence, phase 3 studies were designed on children. The study were aiming to understand pharmacokinetic safety and pharmacodynamic profile, and they had a first study on 12 weeks and then a second follow-up study, which was on 24 weeks of treatment on teduglutide. And then we had also we have also a real-world publication from the Equipe of Madrid on pediatric patients, which I will speak about later. The phase 3 trial had some important key exclusion criteria. So to have a body weight under the 55th percentile is an important exclusion criteria for the study, as we all know that many of our patients actually have a birth weight that is below the 5th percentile, and also to be very stable patients, not to have had major surgery in the previous 3 months. Patients with cystic fibrosis were not able to be enrolled in the study. Patients with intestinal obstruction or some kind of stenosis or intestinal dysmotility were not able to be enrolled in the study. And so this is really important, because we know that all our short bowel syndrome patients are actually patients that have a lot of this complication in the real life. And so we need to understand which would be the best candidate for us. The objective and endpoints of those phase 3 trial in teduglutide was the primary aim, as I said, for the adult population, was the reduction of at least 20% of kilocalorie or volume, and as a primary aim also to enable at least 1 night of PN. The other endpoints were adverse events, growth, safety data, nutritional intake, and also the presence of antibodies to teduglutide, and reduced to PN, and plasma citrulline analysis, and eventually PN weaning. This is the patient demographic of the first study, which enrolled 42 patients from 17 sites around Europe and also around the globe, because there were centers from mainly from North America and England. 30 patients completed the study. This study was to understand which would be the best dose of teduglutide for our children. So they randomized patients into a standard of care treatment. As you can see here from the slide, 5 patients were staying in standard of care, and then they had patients receiving 0.0125 milligram per kilo per day of teduglutide, and then patients receiving 0.25 milligram per kilo per day, and then patients receiving 0.05 milligram per kilo per day. Here you have their characteristic at the enrollment of the study. As you can see, quite broad difference between the medium length of small intestine and also among the different type of resection. In this study, the percentage of weaning was around 60%. The percentage, of response to the treatment was around 60% and was higher for the patients in the group receiving 0.05 milligram per kilo per day teduglutide that had a higher reduced rate. And as we can see also from here, among 40 patients that finished the trial, 4 were able to completely wean from parenteral nutrition, and among the patients that have been weaned from parenteral nutrition, 3 out of 4 had 0.05 milligram per kilo per day dosage of parenteral nutrition. And this is the dose that actually is now standardized for us to be used, because also on the adverse event table that you can find here, there was absolutely no difference in adverse events in giving a higher dose of teduglutide if compared to the other dosage. And so the safety profile was very good because serious adverse events were the same compared from patients treated with teduglutide and patients with standard of care, and none of them was considered related to the treatment. The serious adverse event that you can see here, the only thing that was a bit concerned is the central line infection, because patients treated with teduglutide seem to have a higher central line catheter related infection, while for the rest of the series, which was not judged to be related to the treatment itself. And for the rest of the adverse event, we didn't have any difference to the standard of care. And so the conclusion is that all patients experience more than one treatment adverse event, but there were no unexpected one and no discontinuation of the treatment because of the teduglutide related adverse event, and no serious events because of teduglutide. And this brought to the second follow-on study, which was a 24-week study in which they decided to compare only 0.025 milligram per kilo against 0.05 milligram per kilo per day over a 24-week period, because they find that in the first 12-week the response rate was still not as high as we could expect doing a more longer study. And as you could see here, at 12 weeks we have a response which is around minus 20% of the PN volume and calories, while if we go on, we have a response. We have later responders also that can achieve response at 24 weeks. And as you can see, at 24 weeks, there was a difference in the response of PS parenteral support volumes in patients receiving a 0.05 milligram per kilo per day. And so from this study, as you can see also here, we have the patients achieving the primary endpoint. As I said, patients were around 60%, being lower than 60% of patients achieving these results for the group on 0.025, while reaching a 70% of response in patients on 0.05 milligram per kilo per day of teduglutide. We have to say that one patient also achieved a response in the standard of care group, because we all know that maybe we can enroll patients and start treatment while the process of intestinal adaptation is not completed, and so we have some space to lower the calories and the volume of parenteral nutrition also in patients which are in standard of care. After these two studies, we had a pool analysis of all the clinical studies enrolling 89 patients on teduglutide treatment. There were only 3 adverse events that were considered related to teduglutide, which was one ileus for one of the patients, episode of dilactis acidosis, and an episode of gastrointestinal obstruction due to hard stools. Those 3 adverse events were defined related, while all the other adverse events, as you can see here, was actually unrelated and were not serious. And there was only one patient which experienced death, as you can see here, but teduglutide was stopped and he was withdrawn by EN and PN support, and so the death that was registered in these patients was not seen related to teduglutide treatment. So, the thing that was very important from this pooled analysis of the 4 clinical trial was actually that we can actually develop anti-teduglutide antibodies in up to 30% of the patients, and it was seen that at week 60, so after more than 1 year of teduglutide, around 7% of the patients developed teduglutide antibodies, while around 10% developed teduglutide antibodies after 1.5 years of treatment. But maybe you have experienced a bit also in Latin America. It's very, very hard to have this analysis on anti-teduglutide antibodies, and it's really, really expensive, because we know that the half-life of also if the half-life of GLP-2 analogs is a bit longer, so 1.5 hours more or less, it's very hard to define in this very short period which is the peak of teduglutide, and if we developed antibodies which are really lasting for very, very short period. As I said, there was in 2020 this publication on the use of teduglutide in the real world. It was published by the equipe of Madrid. I think you know the equipe of the La Paz hospital in Madrid, where they have a very huge center on intestinal failure and intestinal transplantation. Since they had a very big list of patients on list for intestinal transplantation, they started compassionate use of teduglutide. So they treated 17 patients, which has all SBS-related intestinal failure. They wanted to evaluate adverse event and efficacy. When we look at the efficacy of this first cohort, we could see that 12 of the patients that were treated in this center achieved 100% PN independency, so the real PN winning, while 4 of them achieve at least 50% PN reduction, and only 1 patient showed no change in PN support. When we look at the patients that achieved PN winning, 3 of the patients achieved this PN winning within 3 months of treatment, 4 of them after 6 months, and 5 of them after 12 months of treatment. When we go to the side effects of the treatment, in the 12 months follow-up, we had only 2 side events that could be related to teduglutide, 1 episode of cholecystitis, and 1 patient developed cardiac decompensation. The conclusion of the study was teduglutide was safe and effective treatment in children with short bowel syndrome, also in the real world, because it promotes intestinal adaptation, and it has a good efficacy in lowering PN support in children on parenteral nutrition. This slide, you probably know it because you all the centers that started use teduglutide should know this slide, which is the checklist that we usually do before starting teduglutide. We had to understand if the intestine is patent, so that there are no adhesion, that the colon is reconnected, that we don't need a surgical lengthening procedure during the period where you are on teduglutide, so you need to be a bit out the surgical option, I would say. It's important to know that there are no mucosal disease, so endoscopy with mucosal biopsy can be mandatory, and the other thing is really important to see is also to find out that there are no polyps, because we know that the only a big issue that has been described in the adult is the development of possible colonic polyp, or also there was another case report of jejunal polyp. That all bacterial overgrowth has been treated, and this is really important, that the patients that we want to start on teduglutide is actually able to get enteral feed, and that enteral feed can be increased, either solid food, either liquid enteral feed, and of course that we are aiming also to correct the weight, so to be aware of over and under feeding. When we monitor our patients on teduglutide, usually we have a weekly monitoring during the first month, then every 2-week monitor until the second month, and then from the second month on, we can have a monthly monitor of biochemical parameters and anthropometry. We always have to record input and output of the patients prior to our appointment, to understand if we have a good reabsorption rate, weight, height, and all the biochemical marker. So after that we have seen all this background, what was the idea basically of our study? Actually, nowadays in Europe, teduglutide was licensed by the EMA, which is the European Medical Association, but as Latin America, also Europe is not it's not run by the European Medical Association, but all national medical association are involved then into accepting this treatment for patients. We are experiencing around Europe a very patchy situation on which are the countries which are actually allowing the prescription of teduglutide in children, and which are the countries which are not. And so we thought that probably having a strong base of data on real-life use of teduglutide all around Europe could help also to understand which were the best candidate, and maybe to make this treatment more available for some of the country. We asked in 2019 for a grant to the European Society of Pediatric Gastroenterology, Pathology and Nutrition to start this registry. That was the principal investigator were myself and the head of my department, Dr. Lorenzo Norsa. And this was spread throughout the network of intestinal failure and intestinal transplantation of the LASPGHAN. The idea was to enroll all patients under 18 with short bowel syndrome that were treated in Europe with teduglutide. The main outcome to measure were, of course, parenteral nutrition reduction of more than 20% in volume and calories, and the percentage of patients which would achieve parenteral nutrition weaning. But we wanted also to understand secondary outcome like pre-existing factor that could affect drug response, and also how we're doing the long-term treatment patients. So we designed a multi-center observational longitudinal retrospective and prospective cohort study. The registry was created to provide safety and validated tool, and the data were completely anonymized. Patients' records were visible only to the PI of the center and to the data manager. This was our timeline. We started in June 2019 with the proposal for the grant. We had actually the approval in October 2020 with all the paperwork. Then we had COVID meanwhile, and Bergamo, as you probably know, was one of the most hit city around the world with COVID. So we needed to delay a bit our schedule. But in March 2021, we finished our registry production. We had our first kickoff meeting 1 year ago, and then we completed the retrospective data collection in October 2021 and started the prospective data collection. And in June 2022, as we were able to present our result at the annual meeting of LASPGHAN, and is where I had the chance to meet the Professor Spalidoro, which I thank. And so we presented our results that I will present right now. We have actually now enrolled 62 patients in our registry. As you could see, the patients come right now from 5 European countries. We can say 4 European countries plus Israel, but Israel is one of our friends and actually part of the LASPGHAN itself. We started the analysis on 54 of these 62 patients, which are the ones that at the time of analysis, which was closed in May 2022, reached at least 3 months of follow-up. Now we can analyze our result. This is patients which achieved 20% of PN reduction. As you can see here, there is a lot. The reduction was defined in 3 different ways, and you will see that I will use the same colors to define these 3 different ways all along the results part. We could achieve PN reduction as a volume, as a 20% reduction in volume. We can have it in a 20% reduction in calorie, but we also use a parenteral nutrition dependency index to understand if those calories were also linked with the weight of the patient. The parenteral nutrition dependency index, which is an index brought into literature by Professor Goulet, is actually based on the use of basal metabolic rate or resting energy expenditure on a non-caloric, non-proteic parenteral intake. Okay, so it's a dependency index on how much parenteral nutrition we use on our metabolic rate. As you can see here, this is the 20% of reduction. If we move to the 50% reduction, we have a lower rate of reduction. Even if also regarding volume, we are still around 70% of patients responding. But as you can see, there are patients that are responding also a lot after 1 year of treatment. You can see from here the 1 year cut. And then we have a 75% reduction. These are less patients. And those patients which achieved 75% reduction are the ones that were toward weaning of parenteral nutrition. But if we look at the response, now we can look about the volume. We had patients which achieved a response in volume, but it's very important to understand that among those patients, some of them had a sustained response, so 50%, but there were also patients that had an intermittent response, so that actually had response, but then lost their response during the follow-up. So when we look at our good results, it's also important to understand who are the patients that actually got the sustained response, because the intermittent one is maybe that we have tried to lower the PN volumes and we didn't achieve, and this was the same, and we have a higher rate of intermittent response if we look to calories, and we have a lower sustained response, as you can see here, and the same if we look at parenteral nutrition dependency index. We have a sustained response in 56% of patients, while we have an intermittent response in 11% of them. Factor affecting response. We tried to assess all the pre-existing factors which could actually be assessed and could impact on the response of treatment. As you can see, if we look at the volume, the length of residual small bowel was very important for responders, but this was like a surprise for us. We had this good correlation with liver enzyme, with AST and ALT. This correlation was also present if we look at responders in calories, and for ALT was also present if we look at response on parenteral nutrition dependency index. We still are willing to understand which is the mechanism. Probably, I think when we have an initial liver damage would probably affect the circulation, the enterohepatic circulation of bile acids, which can maybe affect the response on treatment, but right now this is just speculative. We still need to understand if these results can be confirmed by the increasing of the number of the patients. And when I spoke with Professor Jeppesen about the results, he actually said me that he couldn't really comment on these results, because in the trials that have been made, having alteration of liver enzyme was an exclusion criteria. So actually they couldn't start teduglutide if they had a liver alteration. About PN weaning, among the 54 patients analyzed, 16, so 27% of the cohort were completely weaned from parenteral nutrition support, but among those 16, 2 actually resume parenteral nutrition support. So still the concept of having an intermittent response. If we look at the factor affecting PN weaning, we have, of course, the length of residual small bowel. So we had more weaning in patients that have a longer residual small bowel. We have the citrulline at enrollment. This is the which is probably linked, even if we know that it's not a direct correlation to the length of the intestinal bowel, residual bowel. The patients that were actually weaned from parenteral nutrition were also the one which had a lower caloric need at the beginning, and also the one that has a higher oral input when they started teduglutide treatment. And this is probably very important because, as I said, we need to understand that those patients that have the most potential of weaning are the ones that are willing to introduce more enteral feeds, either via oral, either via enteral tube. If we look at the long-term treatment results, among the 54 patients analyzed, nearly half of the patients were already on treatment for more than 1 year on teduglutide. As you can see, and this was quite striking for me, these are only patients that were actually after 1 year of treatment. Here we define the response on volume, on 20%, 50%, and 75%. What was a bit striking for me is that even patients on long-term results, 20% of them did not achieve any response on volume or on calories and on parenteral nutrition dependency index, when we define the response of having at least 20% of reduction. I think that this should be a question, because I think that when we we need to reassess assess our patients very often to decide if we have a real response to treatment. We would like to understand which are the reason why those patients, even not achieving a good response in treatment, are kept on teduglutide, because maybe there is a response of quality of life, maybe they have improved their episode of small intestinal bacterial overgrowth or occlusion. So there are many things that need still to be detected. And when we have the also when we see at the other part of the slide, when we see at the responder and we try to break the responder in those who had sustained response or intermittent response, still we have a 20% of patients which actually did not have a sustained response of 20% reduction. So this is something to keep in mind. It's a very costly drug. So I think if we want to be, we need to decide some cutoffs at which, if we don't have any response on treatment, we need to probably stop the treatment. About safety, we had only 19 adverse events that was reported. Mainly, we had also in our cohort the more reported adverse event was catheter-related bloodstream infection, even if we don't think that this is actually related to teduglutide treatment. And then we had other adverse events, 7 of them, which were possibly or probably related to teduglutide treatment. And usually they are abdominal pain, the congestive heart failure that we have spoken about, constipation and distension, intestinal obstruction. These are probably the ones that were actually judged related to the treatment. And we know that these are the possible side effects, but none of them was able to exited in the stop of the treatment. And here we have when we developed those adverse events, mainly in the first 12 months of treatment, mainly in the first 6 months of treatment, and then later on other adverse events which are not related to teduglutide treatment. In conclusion, initial response to treatment may be achieved in the first 3 months of treatment, but increase in response in order to achieve weaning may take more than 1 year of treatment, as we have seen. Patients reaching weaning display a more substantial response to treatment. So usually when you have patients that start achieving 75% of reduction, these are the patients which actually will achieve weaning, as we have seen, because among those patients which achieved 75% of reduction, 95% of them actually eventually achieved weaning. Hepatic function might be implicated into response to treatment, but we need to evaluate this further. It is important to reassess all patients in order to stop treatment for those who did not reach a sustained response to treatment after 1 year of treatment. And adverse events are rare, generally not related to treatment, and occurs more frequently in the first 6 months of the treatment. Now we know that there are future perspectives to the treatment of short bowel syndrome, which will come out probably very quickly in adults in the next 2 or 3 years, which are the long-acting GLP-2 analogs like glepaglutide and apraglutide, which are already in a phase 3 trial and that were already published. As you can see here, the phase 3 trial of glepaglutide was already finished, and we have an extension phase 3 trial in adults, where the apraglutide trial, they are starting to recruit the phase 3. These analogs would be once or twice weekly, and so this would be very, very important for our patients, because we know that one of the main difficulties in having this treatment for our patient is the daily injection. And one other thing is this that the newcomer would probably lower the price of our GLP-2 analogs, and this would be very important also to make a good pharmacoeconomic analysis to understand which is the impact, and maybe to like convince those countries which has not yet adopted the use of this treatment for children with SBS. With this, I thank you very much for your attention, and I have to thank all the people that collaborated with this registry with me. We are planning to have a new meeting of the registry in September, in which we will have also new countries that have already asked to be part of the registry, like France and Portugal. And we aim to achieve the target of 100 patients enrolled in this registry in order to have better statistical analysis. So any input from the audience would be more than appreciated. Thank you very much.
Thanks, Dr. Lorenzo, for that fascinating talk. I really enjoyed the overview that you gave us on the teduglutide in advances in recent years and your experience. I think you have one of the largest, cohorts yet described in the world. So I want to invite our colleagues to ask any questions. Pueden escribir sus preguntas en el chat o también pueden preguntarles en español o portugués. Meanwhile, I think I'll start with a question. I think one of the questions that we all have are, what are the predictors of response, of what patients respond better to teduglutide? And I see that that's one of the questions that you tried to answer in your study. And I saw that, there's a lot of debate whether smaller, shorter bowel syndrome is actually a predictor of response or not. And also I found interesting that the transaminases actually were found as a predictor of response. So what I wonder is, did you adjust the AST and ALT by the length of the bowel or by the severity of the intestinal failure? Was that taken into account? Because perhaps I was thinking there could have been sicker patients with shorter anatomy who had more liver disease, and perhaps that's the reason why they didn't, or was it an independent finding that just the liver transaminases on its own were a predictor of response?
Thank you very much, Daniela. First of all, to your first question, yes, the very big issue is to understand which are the predictor of response. As far as I know, in adults, they had some predictor of response on the type of anatomy of short bowel syndrome, because patients which had intact colon were not responding so well as the one without the colon. And this is probably because you have an endogenous GLP-2 production by the intact colon, which would compete on the receptor with the GLP-2 analogs. But we tried to assess this in our cohort, and we were not able yet to find any result on this particular finding, so on the anatomy, as you said. Regarding AST and ALT, this is the question. We did a multivariate analysis, and when we did the multivariate analysis, actually we could not find yet that this is a independent predictor of response, but the statistician said that this is probably only due to the lower number of the patients. She's quite confident that it would probably fit with our response, but still, as we are dealing with rare disease, we all know that we don't have big cohorts that allow us very big statistical findings, but we are quite confident that probably this could be some of the predictors. We will try to assess it later when we could expand the cohort to 100 patients.
Great, thank you.
Thank you, Lorenzo, for your fantastic talk. I think that the most interesting issue of this real life experience is that we could see that we have to wait for some patients, because there are many patients that respond lately. So this is something different from the first. In the beginning, they said if in 3 months you don't have an answer, just stop. And this real life experience has changed a little bit the history. here, well, as Daniela told you before, in Argentina, we have many many centers with many patients, and I have 7 patients in treatment. 2 of them were able to wean off parenteral nutrition. And those 2 patients are one received like the less volume of parenteral nutrition in the beginning. They were receiving 3 days in the week, but they couldn't be able to wean off. And one of them had like issues with the venous access. So these 2 patients, one was short type 2 short bowel, and the other one, it was an ultra short type 3, and they were able to wean, like one of them in 1 month and the other one in 2. But we have an experience with one patient that we persisted in the treatment, and lately at 1 year after, he was able to wean off. So we are very excited with this new tool, because it's something new that we can like have the intestinal adaptation with another tool. So I think Adriana Fernandez is here in the yes, Adriana, are you there? Maybe she has another bigger group of patients with teduglutide, and maybe Adriana, you can tell us. Adriana, ¿querés comentar el número de pacientes que ustedes tienen y cuántos han podido reducir o suspender la nutrición parenteral?
Is here Maria Inés Martinez that can share the experience of Fundación Favaloro, but I can begin with this. It's very interesting, your information. Thank you very much, Lorenzo. We have beginning with the treatment some time ago, before the approbation of the drug in Argentina, because we have patients with severe problems with intestinal failure. So this beginning lets us understand that the drug was gave them a very high benefit, because the 2 of the first group of 5, they could wean of parenteral nutrition in 24 and 29 weeks. One of those patients was a candidate for intestinal transplant. So you can imagine what was that for the family and for the patient. And the other patient was a young boy with 10 years of parenteral nutrition dependence. So we were so surprised of these results. We have a group of very ill patients, and the question that we have now is, which is the best moment for the indication? Chepense has published these different times in a graphic with early adaptation and late adaptation. We know that the first 2 years are so important in the history of these patients. So how long we have to expect the adaptation? The indications say 3 months. That is so short after surgery. But this idea of the plateau, how you think about that? Give me your ideas.
Absolutely. Absolutely, Adriana. Thank you very much for your experience. I think that what you described is a lot similar with the Madrid experience, because they also had very ill patients, and so they decided to start very early, and they asked for England to be like consultant for them to try to heal that patient, to start teduglutide earlier, and this is what they published. I think there is, on your experience, we can understand that much of the problems are also at what time those patients are really referred to an intestinal rehabilitation unit, because we know, and you know as well, probably also in your country, that maybe some of the patients arrive to your attention when they are already very compromised. So those patients would actually benefit from teduglutide because their situation is so low right now. They have very bad venous access, probably an intestinal failure associated liver disease already in place. So these are patients which are really difficult. And so for sure, for them, we need to think about teduglutide. And it's for that that I put it on the, under intestinal transplantation, because I think that, as you said, some patients that we would be candidating for intestinal transplantation need to have a shot on teduglutide to understand if they can achieve something better, or if not, because it's not so always the case. So I really agree with you. What you were saying about the best window of opportunity, this we just finished to edit a long short bowel syndrome position paper from the Committee of Nutrition of LASPGHAN, which I hope would be released by the end of the year, which was done also with the help of Professor Goulet, of Susan Hill. In our position paper, we stated that right now, we don't have any evidence to advise teduglutide under 1 year of age. But there are many buts. So there are many things that we still need to clarify, because probably there is a window of opportunity also in the the very first period after surgery, and this the surgeons are trying to say it very loudly. So, but right now, we don't have any evidence to advise it. So right now, it's very hard for us to advise it below 1 year. But I need to say that there is also the Italian Society of Gastroenterology and Nutrition. It has recently published, I don't know if it's already in PubMed, but will be by the end of the summer, a position statement only on teduglutide by the Italians, which said that probably they would wait until 3 to 4 years to increase intestinal adaptation. This is a question. Why? Because if we start at 1 year of age and then you wean off parenteral nutrition, are you 100% sure, Adriana, Veronica, and the rest of you, that this patient is actually weaned because of teduglutide and not because of his intestinal adaptation? First question. Second question, if you are not 100% sure, when are you willing to stop teduglutide? Because this is the other problem. We start, we wean, and then we never stop. Because we know that when we stop, we did some, I don't know if you did it as well, but we actually did some trial of suspension of teduglutide, and they just go back to their normal situation.
Adriana has experience in stopping teduglutide. For example, I have a patient that has difficulties to receive the medication at home. So when he's having only 10 doses, I say, well, go 1 day on, 1 day off. And he's doing well. He's
Absolutely.
The one that he went off at 2 months after. And today he's 3 years follow up with 1 day on and off teduglutide.
This was also this is also one of the questions we pointed out in the recent position paper on understanding which there are probably patients that can have only one day out of 2, having other dosage. So of course there is no clear cut yet, I think.
But we need more information, of course,
that
is really, but we have some experience with adult patients who could have an indication 1 day yes and 1 day no, and after 6 months they could suspend, and they did well. So we did that with 2 one pediatric patient and one adolescent that could, if we have the same positive experience. But this is the real world, you know.
Exactly.
It's only very few patients, but perhaps in the mind we have the idea that some patients could be improved for some time with teduglutide. We have many problems with venous axis, and in the history of the short bowel syndrome, we lost patients because of that. It's the first indication for transplant here, and that is, well, something that we have to take in mind and to follow up very close the patient and give him whatever we can. I don't know.
Lorenzo, here in Brazil, we just had authorization to use in children the teduglutide. So we have no experience with children. We have some experience in adults, but very few. I have a couple of questions. First one, I was surprised when you showed the D-lactoacidosis as side effect. That could be, in my thoughts and some reading that I had, that D-lactoacidosis could be a good indication included to teduglutide, because it's really absolutely related to the absorption. So I'd like you to explain a little bit about this, please.
Absolutely. Thank you very much, Professor Spalidoro. It's a very, very interesting question. I have the same feeling as you have, like the lactic acidosis is actually one thing that could improve with the use of teduglutide because we have a better absorption. And I personally, I have one of my patients that I follow up with a very short bowel syndrome on teduglutide, which had a lot of the lactic acidosis events. And after teduglutide, she improved really well, and she's now weaned off parenteral nutrition. But I think that, of course, when we have the side events, we always put all the side events that were having during the treatment, and the lactic acidosis can be a side event because it is known, and I don't know if you have the same feeling also for your patients, that when they are starting to have teduglutide, they start to have a higher intake of, they are more hungry, they want to eat a lot more, and if they start eating a lot more and they start eating a lot more of carbohydrates, then they probably can develop the lactic acidosis because of an unbalanced diet, because also these patients which I was talking about that was weaned when like she's a teenager. So as all teenagers, now it's summer, she was going to concert with their friends. It's summer here in Europe. I know that in your countries is winter now, but and so she have been weaned, she was off parenteral nutrition, and she started having a normal life, going out every night, eating much more outside, and so she started having new event of the lactic acidosis. So I think one thing which is important is to have a good dietetic advice when we're weaning those patients, to have a diet which is balanced in lipid and carbohydrate intake, because we know that the lactic acidosis usually comes when we have higher carbohydrate intake.
Yes, thank you for this answer. The other point is, I understand that it's as this a very expensive drug. So with the time, with all this experience that everybody is going to start to have, I understand that we are going to find the best patients that we can use this drug. So then we can really maximize, I would say, the effect, or to choose the correctly patient. And I think that if you have a patient that the parenteral index is dependency index is above 0.5, that's not a good patient. I think that we should choose patients that it's already going for the. In my experience, I have many patients that their parenteral index is 0.23, 0.4, and this patient, they stop to go red. So I think these patients could be a good patient for really to get the winning of parenteral nutrition with teduglutide. So I understand that if we choose the correct patients, with the time we will be able to do that, the results will be much better with teduglutide than we have at this point. What's your opinion about this?
I totally agree, but I just need to add one comment, because I think we all deal with patients with parenteral nutrition, and the one which are actually stuck on 7 on 7, and these are the one which has usually a higher parenteral nutrition dependency index, are the one that has a very, very difficult life. And for my opinion, like, this is personal experience, but when I experienced one mother that cried just because she had one night off, I could imagine what is the, like, also for those patients, which is the impact of only having one night off or maybe 2 nights off. It's a big impact. So I think that I totally agree that right now it is so expensive that we need to aim for those patients which we know that will be weaned off, because for them we have a really, really good chance, and we have a really good balance between the pharmacoeconomics. So we have a good balance between the costs and our goals. But I hope that in the future, with the comings of the new drugs, the ones that are long-acting, and so probably the market would be much more flexible. And maybe teduglutide will lower the price, and for sure we know we will have probably new biosimilars and stuff like this, which we already had for intestinal IBDs, and so if we can, the price would be lower. I would advise also the patients with a higher parenteral nutrition dependency index, because they can really increase their quality of life a lot. Really a lot. And studies on quality of life are lacking yet in this setting. And there are many patients that are actually report to have a very, very different quality of life. All the patients which had maybe many episodes of intestinal distension, small intestinal bacterial overgrowth, which with teduglutide had less distension, had less abdominal pain. Those patients are not taken into account right now, but we know that in our children, quality of life and quality of life of the family is important. So I think it's a question of balance right now, and we need to find the right one.
Thanks, Lorenzo.
Daniela, one more point I'd like to say. It's when we talk about teduglutide for children, the vials of teduglutide, we have a lot that supposedly we threw away because we use just a few amounts. You are close to these people in Europe. Why they don't do shorter vials, or maybe allowed to fraction for many patients with the same vial? So we could help 3 children with 1 vial, and we threw away 2/3 of the vial. So this is something that should be changed.
Just to add on that, I think we've discussed it in our working group before, but as part of my PhD, I'm doing a health economic evaluation. Part of it, I'm looking at the cost utility of teduglutide. We know that Vik Raghu in the US published a study where he showed that teduglutide was not cost effective currently, but however, we find that if we model the cost of teduglutide based on pediatric age dosing, teduglutide actually becomes cost effective as a strategy in children with intestinal failure, when you consider that intestinal rehabilitation is an expensive disease, and parenteral nutrition, home parenteral nutrition, development of central line infections, changes of central line, thrombosis, and oxyperin adds to significant cost. So I agree with Dr. Spolidoro that if we were able to convince the industry to start developing not 5 milligrams per vial, but smaller, because we're only using 0.05 per kilo, and especially in small children, that accounts for over 80% of the valve being lost, I think it would be very impactful in terms of cost and access to treatment.
Absolutely, and I think it's for that we need to have a higher amount of data, because to have a class action among us to try to impact on industries, because for them, of course, it's better to have everything thrown out. Of course, we know that. But if we can have some more data on HTA, as you are doing, probably this would really, really help. And I think on HTA, but the study that you mentioned probably did not take into account the patients that actually, without teduglutide, would develop intestinal transplantation. Because we all know that if they go to intestinal transplantation, then the economic impact, even if I know that in the States, they still have a lot of faith in intestinal transplantation, but the economic impact of the long hospitalization for intestinal transplantation is huge. It's massive. It's 1 year hospitalization, re-hospitalization every now and then. So I think this was not yet taken into account for many of the children.
Okay. I think I'm mindful of the time, everybody's time, because it is a Saturday and it's 4:15. I think maybe Dr. Fernandez had one last question.
No, because I will ask about the dose, the pediatric dose. So is Polidoro just comment that. Thank you.
Okay, thanks everybody. I had a lot of questions, but I think we went past the time, and it was a fascinating talk. I think it was a great discussion. As you heard, our colleagues in Argentina are leading the experience in the region, and I'm hoping now Chile also received approval. We'll start recruiting patients. In Toronto, where I'm currently working, we have 14 patients. We just recruited a 15th one, and so far, going back to Dr. Polidoro's comment, we have a mix of patients. We have some very short, even some almost duodenal colonic anastomosic patients that we really debated whether to consider them or not. And we have other patients that are on TPN for a long period of time, 7 days a week, that have not been able to wean. But I think we're hoping to make an impact on their quality of life, as you said. And I think there will be more to come in the following years once we have more experience and larger cohorts. So thank you very much, Dr. Lorenzo. It was a fascinating talk. It was an honor to have you here, and we'll be in touch. So thank you very much.
Thank you very much to all of you, and have a nice Saturday.
Thank you. Have a nice weekend.
Thank you. Bye.
Bye.